Okay, I have noon, so we'll get started. Good afternoon, everyone. Thank you for joining us for our quarterly virtual council meeting. I'm Brandy Vinson, the Executive Director for Quality Insights Renal Network 5. Before we get started today, I'm just going to go over a few housekeeping items. All of your lines have been muted. This session is being recorded and will be posted on our website along with the slides, hopefully by Friday, if not early next week. If you have any questions as we go, please put them in the chat. And I have other members of my team who are great about responding as they come up. If there are any questions left at the end, then we will definitely take time to cover those. I should have deleted that last bullet point, and now I'm concerned I have the wrong set of slides. Because I thought I deleted it. There's not an evaluation at the end. Feel free to provide any suggestions for improvements anyway, but there won't be a link to an evaluation at the end. Okay, so what I hope to cover today is providing an update on our network goals, celebrating the improvements that we've already had by recognizing some facilities. We'll review network expectations, key takeaways, and then I'll share some FAQs with you all, and then we'll take time to address any questions that you all have. So for those of you who are new, I typically like to start these sessions off with a review of the conditions for coverage, just to help strengthen the relationship between the ESRD facility and the network. So what I will stress here is that the governing body of the dialysis facility should act upon recommendations from the ESRD network. The dialysis facility must cooperate with the network designated for its geographic area. So for us, it's Network 5. The geographic area is Virginia, West Virginia, Maryland, and DC. You work with us to fulfill the terms of our current statement of work, which I'm going to go over in just a minute. And then each facility must participate in ESRD network activities like this one and pursue network goals. So our statement of work is divided into 3 areas: patient and family engagement, quality improvement, and data. And then health equity is integrated into all 3 areas. As a reminder, and for those of you who are new, our statement of work is our contract with the Centers for Medicare and Medicaid Services. It's a 5-year contract, but it's divided into 12-month performance periods called option periods. The period of performance runs May 1st to the following April 30th, and our current performance period is May 1st, 2024. It runs until April 30th of 2025. We often refer to it as option period 3. Okay, so now getting into our statement of work and all of the topics and goals that we're pursuing. We'll start with home modalities. Right now, the goals are to achieve a 15% increase in the number of incident ESRD patients using a home modality for dialysis. Those patients that we're looking for to increase the use of home modalities are within that first 90 days. The second goal in this area is for prevalent patients. So any other patient, and that's really patients moving to a home modality. CMS has made some tweaks to this goal this performance period. That's why you haven't actually received home goals yet. We did get an update this morning. It looks like they're getting very close to finalizing the data. So we will be in touch with facility-specific goals very soon. So that leads us on to transplant. So the same 2 goals remain in this area. We're focused on waitlisting as well as transplants. So that's patients actually getting a kidney. So all of these measurement slides will look the same. The royal blue bar is our baseline. The navy blue bar in the middle is our current performance, how we're doing so far, trying to reach the gold bar, which is our goal assigned by CMS. So let's take a look at waitlisting. I will remind everyone here that waitlisting for the network goal is adding patients to the waitlist. So it's not overall how many patients you have on the waitlist, it's adding patients to the waitlist. So we are well on our way to reaching this goal. Our network historically performs very well in this area. Transplants, there's a data lag here, so our performance doesn't look quite as well as it should, but we feel confident that we will reach this goal or get very, very close to it. So keep up the good work in this area. I do want to recognize the following facilities for their performance so far. We're looking at data up to August 31st, and I'd like to recognize DaVita Annandale, who has already added 5 patients to the transplant waitlist this performance period. RAI Chesapeake Avenue Newport News, who has added 7 patients, and then DaVita Tidewater Home, who has already added 12 patients. That is incredible work, and we appreciate your contributions to meeting the network goal. For transplants received, FNC Prince William County has already had 9 transplants this performance period. That is absolutely incredible. Renal Care Group of Martinsville has had 5, and DaVita Petersburg has already had 4. So great work, everyone. Please keep it up. If you all, if you haven't been recognized on this list and you have questions about what these facilities are doing, certainly encourage you to reach out to them and try to collaborate, but also contact the network and we can share some ideas as well. Okay, moving on to vaccinations. You might remember we have several measures in this area, but we're looking at vaccinations for COVID-19, pneumococcal, and influenza. For COVID-19 and influenza, we're looking at vaccinations for patient and healthcare workers. Pneumococcal is strictly patients. So we'll start with the COVID patients. CMS has switched up the goals for these measures. We're looking to improve better than we did last performance period. So at the end of April, we were right about 6% of our patient population had been fully vaccinated for COVID-19. So we're aiming for about 7%. The navy blue bar shows that, we're headed in the right direction, but as we all know, the definition for fully vaccinated changed right at the, correct me if I'm wrong, Amanda, if it was the beginning of September or the end of August. So we really kind of start back at 0. So really encourage you all to offer these vaccines to your patients in clinic, and if not, then continue the education and encourage them to get vaccinated in the community. Same thing with staff for COVID vaccinations. We're starting back where we were at the end of April and trying to improve the rate of staff members who are vaccinated for COVID-19. Pneumococcal tells a more positive story. We are headed in the right direction there, trying to get to almost 47% of our patient population being fully vaccinated. I'll have more on that in just a minute. For influenza, the goal for patients is 80%. Last performance period, it was 90%, so they actually lowered the goal. We don't have any data for this yet. We will at the end of this month. So knowing that flu season just started, so make sure you're offering the influenza vaccine to patients and your healthcare workers. The goal for staff for influenza is a little bit different. CMS is looking at where did we end in April, and again, trying to improve. So we start back at 0, and we need almost 58% of healthcare workers vaccinated for flu. Okay, this is a new slide that I've never shared with you all before, but I'm hoping to appeal to your competitive side of healthcare quality improvement, and wanted to let you all know that we're tracking on the organizational level how each organization in our network is doing with vaccinating their patients for pneumococcal. So this is making sure that your patients are up to date. Really, we should be at 100%, that every organization has made sure that their patients has the vaccines that they need and are vaccinating them if they are due for one. So what I will point out here is we consistently have the red bar and the purple bar being the lowest rate of patients fully vaccinated in our network. So that's DaVita and ARA. ARA is now Innovative Renal Care. So really encourage all of you to take a look at your pneumococcal vaccines and get your patients up to date with the vaccines that they needed. There are resources available in EQRS to help you with this, especially this pneumococcal. You can log into EQRS and see your patient level data, what patient is due for what vaccine. And then there's also an influenza dashboard that will help keep track of which patients need to be vaccinated. If you have any questions about vaccinations, please contact Amanda Morelli at our network, and she can help you with these things. She can kind of give you some instructions of how to access the EQRS dashboards if you need help with that. Her contact information will be on the second to the last slide when we get to it in just a little bit. I do want to recognize these facilities for meeting their pneumococcal goals for this performance period already. So we're 5 months into the performance period. We have data for 4 months so far. So again, looking at as of August 31st, RAI Thimble Shoals Newport News, BMA North Roanoke, BMA Roanoke Salem, DaVita Hopkins Road, FMC Prince George's County, DaVita Puddle Dock, DaVita Hyattsville, and DaVita KidneyCare of Laurel have already met their pneumococcal goals. So great job. Thank you for leading the way for pneumococcal vaccines. Okay, for hospitalizations, we continue to have 3 measures in this area: patient admissions, ED visits, and unplanned 30-day readmissions. I'll remind you that the gold bar is an upper threshold that we are trying to stay below. So at the moment, we are below the threshold in all of these areas, but certainly we are getting close, so need to really focus in these areas. I will ask that if you are seeing an increase in your ED visits due to vascular access issues, I'll ask you to contact Caitlin Booth at the network so that she can document this. We are trying to keep track of this, as well as trying to identify some resources to assist with this issue and trying to keep CMS abreast of what is happening. You might be aware of the sepsis campaign that is currently going on, and we have really enjoyed receiving pictures from facilities demonstrating the bulletin boards and the patient education that they are providing to patients around this area. And I'd like to recognize DaVita Covington, UVA Amherst, FMC Middle River, DaVita Greater Charleston also did a hand washing activity and used a blue light to show that the hands were still dirty after washing. So great activities being done in this area to support the sepsis campaign. Earlier this month was World Sepsis Day, and we encouraged everyone to wear pink. We have the FMC Denby home team who got involved, including their medical director, and then IRC Capital Dialysis really showed up, and all of their staff participated by wearing their pink scrubs. UVA Amherst as well, and they modeled in front of their patient education information on the topic. So love seeing these and really appreciate you all participating and sending in the pictures to share with us. Alongside the sepsis campaign, we offer a sepsis quiz every week. You all might know it as Lattes for Learning. And I'd like to recognize the winners for the past 3 weeks. Janine Scott from UVA Amherst, Victoria Kerr from UPMC Western Maryland, and then Corey Jones from FMC Tappahannock. So congratulations. And again, thank you for everyone who is participating. Unfortunately, we don't have the budget to provide prizes for everyone, so we're having to, draw names out of a hat, but love the participation and seeing everyone engaged in this activity. Moving on to patient and family engagement, this is another area that we have 3 measures for QAPI, encouraging patients to participate in your QAPI meetings. Life plan is when a patient identifies a goal, a self-directed goal that they are working to achieve, and then peer mentoring, that's patient-to-patient mentoring. We have already achieved goals in life plan and peer mentoring, and as you can see, very close to achieving the QAPI goal, but need facilities to continue engaging patients in all 3 of these areas. Now for some facility recognition, FKC Allegheny has done a great job of incorporating life planning. They shared examples of patient self-directed goals related to nursing and the dietitian. So one patient's personal goal was to obtain a personal aide or healthcare partner to assist him so that he could start home therapies as home hemodialysis. Another patient wanted to improve eating better so that their overall health would improve. So love seeing those. That is how you get credit, is you actually have to send us the goal, fax that information over to Renee. The next group of facilities have been active in all 3 patient and family engagement measures. That's FKC Elkton, UVA Augusta, UVA Amherst, UVA Stanton, and FKC J. Robert Pritchard. Then the next group of facilities have participated in 2 out of 3 patient and family engagement measures. DaVita Bertha Cirque, DaVita Falls Road, DaVita Forest Landing, FKC Middle River, Renalis Capital Region, DaVita Stanton, FKC Louisa, FKC South Richmond, FKC Halifax, UVA Zion Crossroads, UVA Orange, UVA Page, and UVA Culpeper. For data quality, these measures focus on getting the 2728 and 2746 forms entered into EQRS on time. And as you can see, we have met both of these goals, but again, these goals have to be sustained. So that means do not let up and continue to get your 2728s into EQRS within 45 days of the first date of dialysis, and then the 2746 within 14 days of the patient's date of death. So identifying facilities to recognize in this area is really difficult because we have a lot of facilities doing great things with data entry. So what I decided to do for today's recognition is to look at the facilities who have 100% of their forms entered into EQRS on time, but they also have the highest volume of forms to enter. So at this time, I'd like to recognize DaVita Puddle Duck, Forest Park Dialysis, BMA Farmville, DaVita Frederick Dialysis, BMA Roanoke Salem, DaVita Cambridge, ARA Mechanicsville, Fresenius Medical Care First Colonial, DaVita Hartford Road, UVA Zion Crossroads, DaVita Amelia, Artificial Kidney Center Suffolk, UVA Orange, Deer's Head Center, IDF Calvert Center, and IDF Chestnut Square. Thank you. Please keep up the good work. You're really setting the bar very high that this can be done. That was a mistake. Option period 3, site visit. So you all might remember that CMS is requiring us to visit 25% of the facilities in the network. We have here that it's going to be 113 facilities. It's actually only going to be 110. The list of facilities is available on our website. We like to be completely transparent of who is getting a visit, but you also will be notified 30 days in advance of the exact day that we will be there. These facilities are prioritized by zip code, and they're located in disadvantaged communities. So CMS provides a list of facilities that we have to visit. After we visit all of those facilities, then we can select the facilities on our own based off of data, our interactions, grievances, IVDs, and that's how we'll make up the bulk of the 110 facilities that we're visiting this performance period. We do strongly suggest that the interdisciplinary team is in attendance for our site visit. We have started to do a network assessment of the site visit. So we are assessing how our experience was on site with the facility, and we're looking at 5 areas. Staff engagement, so the staff who were in attendance at the meeting, how did they engage with us? We're using a Likert scale of 1 to 5, 1 being not at all satisfied and 5 being very satisfied. We're looking at the staff on site who was actually involved in the meeting. Was it the interdisciplinary team like we requested? The amount of knowledge that the staff has about the network. Did the staff complete the pre-work, and then understanding of the ESRD facility reports. You'll see that our greatest opportunities for improvement are completing the pre-work. So facilities before we arrive on site are asked to do a couple of things. One of them is to watch a short, less than 20-minute video about the network. Not only the staff who's going to participate in the site visit, but all of your staff. That's a great way to increase the score on knowledge of the network, is by watching that video. Letting the patients know that we're going to be on site and offering them a chance to talk to us if they're interested. That's a great way to get this score to go up. And then the understanding of the ESRD facility reports. So joining meetings like this, calling the network and asking for help with your ESRD facility reports are great ways to increase the score for this area as well. So I'm going to drill into the ESRD facility report just a little bit. The network's going to continue to provide data feedback through our ESRD facility report. This provides facility-specific goals on each of the network measures, and it helps provide an update each month on how your individual facility is doing meeting those goals. The expectation is that a facility representative will access the report monthly, and that action plans to meet network goals will be discussed during QAPI meetings and documented in your in the minutes of your QAPI meetings. To help, the last week of each month, so this week, I send an email to the facility administrator, the medical director, and social worker, notifying them that the report has been updated, and I provide the unique username and password to access the report every single month. We monitor this to see if the report is being accessed, and we share this information with the state surveyors when they are on site to do your surveys. So we are working on creating a resource that will go on our website. This is the ESRD facility report, frequently asked questions. So I'm going to go over a few of these in an effort to address questions that you all might have. So where can I find the facility username and password? In the email that I send to the medical director, social worker, and administrator every single month. It's your username is your 6-digit Medicare provider number, which, by the way, is the most important number that the network uses. So I really recommend you all writing that number down, putting it on a Post-it note, sticking it to your computer monitor or on your phone, so that when you're engaging with the network, you're able to provide that number to us. If you give us your clinic number, we have no idea what that is. We strictly go by the 6-digit Medicare certification number. Another tidbit, usernames and passwords do not change. They are unique to the facility, not the user. So managers, facility managers, medical directors, and social workers, feel free to share that information with other staff members. That is completely okay to do. Sometimes I get a request to reset the password. There is no resetting the password. The password and the username do not change. Another question we get a lot is, where does the data for each measure come from? So our data is provided by the ESRD National Coordinating Center. We refer to them as the NCC, and they are another contractor for CMS. So CMS has the networks, and then they have the NCC. The NCC gathers all of CMS's data and then delivers it to the 18 ESRD networks across the country. So data is collected from multiple data sets, including EQRS, NHSN, UNOS, and Medicare Part B claims. The good news is that under each measure in the ESRD facility report, the source of data is displayed. So I have just a little example here. This is one of the hospitalization measures, and you can see right here it says data source fee-for-service Medicare claims. You will find the data source on every single one of the ESRD facility reports. Why does the hospitalization data not match our internal hospitalization data? That is a great question. And I will let you know that the network's hospitalization measures only include hospitalizations for a diagnosis with certain ICD-10 codes that CMS selected. They really wanted to focus on admissions that they felt the ESRD dialysis facility could help impact. So any patient admitted with these diagnosis codes will appear in our data set. Patients not admitted with these codes will not appear. In addition, that data only pulls from Medicare Part B patients. The codes are pulled from Medicare claims only and are not affected by any organizational documentation that you might have internally. Why does my data appear to be inaccurate? Well, there are a few reasons that might be the case. First of all, there's at least a 30-day lag for most data received by CMS, and sometimes it's longer, like for the transplant data that I just shared with you. Medicare claims also usually lag about 90 days. So data attribution is also dependent on timely submission of the information into the appropriate database by the facilities. Additionally, the measurement period for CMS runs May to April, and not a traditional calendar year like most of your internal measures probably run, as well as the QIP and 5-star data. Therefore, discrepancies in the data could be due to the time frame difference. For example, a patient added to the transplant wait list in March of 2024 would be attributed to the prior measurement year's performance. So that's not going to count towards your goal this performance period. Can you separate home versus in-center data? Unfortunately, we are not able to do that right now. This is on my wish list of things that maybe we will be able to do at one point, but data, again, all comes under your CCN. So Medicare is looking at your one facility under your 1 6-digit CCN number and looks at all of those patients collectively. They're not dividing them out by home or in center. Can you provide patient details in the ESRD facility report? At this time, we're unable to do that because of security concerns. Again, this is another wish list item for me, but we can't do that in case there were a data breach and a hacker would be able to access patient level data. However, if you want patient level data, definitely contact us and we can provide you that information either via fax or managed file transfer. So we can definitely get the information to you if you really need it. Okay, finally, what does project year mean? I wish this was like an interactive and you all would yell out. Project year refers to the 12-month contract period, which is May 1st until April 30th of the following year. Okay, so like I said, this is going to be available on our website. So look for that coming soon. But most importantly, do not hesitate to contact the network if you have questions about your ESRD facility report. All right, a review of network expectations, engage with us, respond when we send you emails and request information, take action on those things like your ESRD facility report, sign up and read our electronic newsletter alerts. That's a great way to stay in touch with the network and see what's going on. Notify the network of major events like facility emergencies and closures. Even if you're just closing down one shift, keep us abreast of that information, changes in leadership and your staff. Inform patients of available network resources, the grievance resolution, educational materials, opportunities to join and participate in our patient and family advisory committee. And then pursue our goals. So participate with us in our quality improvement activities, engage when we're doing technical assistance, either virtual or on site, and then access that ESRD monthly ESRD facility report every single month. In closing, all facilities are required to be working on all network goals, so trying to make progress on all of them. Individual projects might focus on a few specific goals, but this does not disqualify the facility from making progress on the others. And then engage with the network. The conditions for coverage require it. Now I'm going to have to do this by memory because I updated these slides this morning and the slides that I added are not here, but they were great. They were all about the health equity QIP measures. So CMS released 3 quality improvement measures around health equity. One of them is being implemented this year, and that is that the facility needs to attest to committing to health equity, and you do that in EQRS. At this time, only 7% of the facilities in our network have done that. So if you need help with that, then please let us know. Andrea Moore is the person to contact, but we have 2 awesome resources on our network, on our health equity page, that will help you with this. One is an FAQ that just kind of gives you the tips on how to do it. And then another one for those auditory learners is about a 30-minute video that will really walk you through it and address any questions that you might have about that. But again, if you need help directly, contact Andrea Moore and she can help you with that. Shout out to UVA. All of their facilities have already attested in EQRS and they are leading the pack in that area for us. So thank you so much for doing that. And like I said, anybody else who needs help, please let us know. Okay, what questions do you all have for us? Awesome. Andrea put the resources right in the chat, so that makes it super easy. Any questions? Yes. Thank you, Andrea. I swear I don't know where the updated slides went that I just did this morning. So our community asset profiles that Andrea has been building for our communities are now available on our website. She put the link in the chat, but this is a great way to go and check out and find resources to help address any social determinants of health gaps that your patients might be experiencing. So Andrea, thanks for the reminder about that. All right, if we don't have any other questions, that will conclude the presentation for today. I do appreciate all of your time. If you need anything, don't hesitate to contact the network. Otherwise, have a great day. Bye-bye.